everyone. This is our final panel time of the afternoon today. We will be back on tomorrow at 8 a.m. Pacific Standard Time and 10 a.m. Central Standard Time. But if there are any other questions, feel free to ask them or place them in the chat. We have Dr. Tandon, Dr. Patty, and Jessica Johnson, who you heard from in the last session. So if there's any questions, please unmute yourself and ask, or you can leave those in the chat.
Well, clearly you guys were very, very clear in whatever you all said, and everyone is convinced that there's nothing to ask. Is it just the people that I see on the Zoom that are actually on the Zoom?
Yes, but the meeting is recorded.
Got it. Okay. We'll get a couple of minutes, I guess, right? Sandipan, any thoughts? How was your presentation? How was the rest of the day?
I think it was great. Actually, all the talks went very nicely. A nice flow, I would say.
Good. We've been interviewing residents. We just finished interviewing. So.
Okay.
Yeah. Good.
We had a few questions in the chat box earlier. I know you answered one or two of those, Dr. Patty, if you wanted to elaborate on any of them that were asked earlier.
So I think one of the questions that was asked before, and I think now that Dr. Tandon is there, I think it would be also good to give some perspective. One of the person asked that if we think that epilepsy surgery is so effective, why do we not give before medication or initially, and why do we wait for 2 or 3 medicines to be intractable and then we start the process?
Yeah, no, I think it's a great question, and I think the field is moving. And let me say a few things about this. You know, there are situations where we don't necessarily wait for people to fail multiple medications. And a very great example of that are people with cavernous malformations. So these are small vascular malformations that ooze and bleed in the brain. And for decades, people have been taking them out when they present in people with seizures, because the likelihood of seizure freedom with that operation is so high, right? So the probability of being seizure free after a cav mal resection is 90%. You're removing a abnormality, you're not really removing much functional tissue around it. And so the probability of decline is small, the probability of success is high. And I tell all my patients, like, it's all this balance, the risk and benefit. You want risks down here and benefits up here, and cav mals have that greatest separation between those two. But that is also true for other lesional epilepsies. And I think all of us, when we see a patient with mesial temporal sclerosis, for example, the idea that we got to keep failing multiple medications kind of goes out the window. And so practically, we don't push it in those situations. The situation where I do think it is different is when it's a non-lesional epilepsy, where there is not a clear site of seizure onset. And very often, the process there means that, implies that the patient is going to get intracranial electrodes implanted, get a resection, and that resection is not going to be of just scar tissue or abnormality. It's going to be of tissue that has normal neural functioning at some points, and other points is engaged in making seizures. And so the threshold there has to be higher, because we definitely want not to, diminish someone's functional level and yet to alleviate their epilepsy. And so the gap there is between risk and benefit that I showed is closer. Well, depending on the location, which hemisphere, which part of the brain, it matters in different ways. So yeah, and there are a few others. I listed cavernous malformations and classical hippocampal sclerosis visible on imaging, low-grade tumors of various types. When we see those, again, our threshold for intervention is very low. And sometimes we have patients who've just been on one medication. We perform resections. People with very obvious focal cortical dysplasias or bottom of sulcus dysplasia, again, it's the same thought process. But the patient is part of that dialogue, that decision tree, and they need to understand that we're open to the idea of surgery in that context because they are lesional and because the lesion is easily accessible, and the probability of a decline is very small, and probability of success in seizure alleviation is very high.
Thanks. Agree.
Was there another question, Morgan?
You had one about, let me read the question for you, on ketogenic diet.
Yeah, but it was in the chat. I remember asking about ketogenic diet versus just supplement with ketones.
Yeah.
I'll let you take that, Sandipan, if you
Yeah,
know the answer.
I answered that, but essentially what we want to say is that ketogenic diet is not just supplement of ketone, but it's an entire planned regimen where there is a lack of sugar, and the goal of this is to actually switch the brain metabolism from using sugar, which is often the brain tends to use, and convert it into fat, And by doing that, we are trying to sort of prevent the pathways that incites seizures. So in ketogenic diet, it's very regimental with the lack of sugar, including some of the medications need to be coated. You need to have a dietitian. So that's planned process. So if somebody is just having ketone supplement, that was the specific question, and having all the other things, it might not work.
And another question that we got was, when timing a tonic-clonic seizure, what is the stopping point? When they stop convulsing or when they're able to communicate again?
Oh, I see. That was okay. So yes, normally we tend to say if the seizure lasts longer than 3 to 4 minutes, that's when we start getting worried, and the probability of seizure stopping itself decreases as the time increases. The key thing is that once the seizure part stops, often patients are minimally responsive. And at that point, I think trying to wake the patient up is clinically relevant. And that time, if the patient is not waking up, and if that is something unusual, that's the time then they should call 911.
So those are all the questions we got. Thank you all for your help.
Okay.
I'll just say one other point here. We've been, for anyone who's listening and also for people who listen to this after it's been recorded, we're very likely to have a symposium on epilepsy in the spring in Houston. And we invite any of you who are interested and engaged in coming and joining. There'll be a patient-facing portion of that as well. Of course, a large part that's going to be for providers and for CME. So hopefully we get that organized and in place in March or April.
Great. Thank you, Dr. Tandon. Thank you, Dr. Patti. Thank you, Jessica. We're in the session today, and we'll continue tomorrow morning.